All right. So I guess Len didn't even want to attend my talk. I think that says something. So the word of the day is Salt Lake City, where I was born, and my dad was in residency and set a record for the amount of skiing days. Just so everyone knows, this is the last teaching series of the year, other than the end of the meeting, which is about a month from now. So nobody show up next week. So first off, I'd like to thank Amy, who's been coming in to help me set up. She actually comes in the night before because this room's a disaster every time we walk in here. Every time it's in different configuration. And she's not only done that, but she comes in early to help me get this configured, which can be tricky. And she's also covered for me in the few days I've been gone this year, which is a very anxiety-producing situation, a GERD-inducing. There's probably a few EOs in your esophagus when you're coming in here, but no, I really do appreciate all your help. And she's moving on to bigger and better things next year, so we're going to miss her.
Handbag company. My own.
Good for you. I'm kind of glad Len's not here, so I can say how disappointed I'm not disappointed. When I saw this on my list of topics this year, and I gotta say I wasn't thrilled. Just like I wasn't thrilled when I see these patients on my schedule in the morning, because I'm never quite clear on our role, especially given I see mainly adult patients. But after this, this is less of an update and more of a review of the literature on the staples of both diagnosis, treatment, and things of that sort. And I think after having to go through all of this, I do have a better grasp of what I believe that our role as allergists, both in the adult and the pediatric setting. I know a lot of you out there have more experience with this, especially those that trained at CHOP and things like that. And, Frank and everyone, so feel free to chime in if you have anything to add. We can go through all this. So no disclosures relevant to this talk. So I'm going to go through a very brief history of EOE because there's not a lot other than the last few years that has come out in the literature. So it'll be very brief. Focus a little bit on the pathophysiology and some new diagnostic modalities and treatments that may be coming down the pipeline. Some epidemiology of this and the fact that it's increasing and whether that's due to the fact we're looking for it more or whether it is truly increasing. I think it's probably a mixture of both. Associations with other atopic disease and more importantly, the associations with foods and if there's a role for that diagnosis. When I see patients with fellows or in my clinic by myself, I usually discuss these therapies, but I hadn't really read through the papers that recommend these treatments. So we'll go through some of those and also look at some other therapies and basically looking at some other clinical trials that have largely failed. But there may be some others coming down the pipe that we may be able to use for this in the future. One of those is Zillner, which, to cut to the chase, really does not have a role as far as my reading of the literature. But Dan covered this earlier in the year, and if we have time at the end, I'm going to go through some new data that came out of the University of Utah about food-specific IgG and the possible role of plasma cells specific for IgG4. The history, I only have one slide. So we've been seeing these type patients with this clinical picture for many years. In 1966, there was what's thought to be an EOE patient documented. 1978, the year I was born, they diagnosed another. But looking through PubMed, from 1981 to 1987, there were only 20 citations that I could find on eosinophilic esophagitis, which is incredible. In 2014, there were 247 that I was able to find, probably much more than that. So there's been an exponential growth, an avalanche, if you will. What that means diagnostically, clinically, things like that, at this point, it's hard to say, but I think new treatments are indeed on the way. So the pathophysiology, I found this interesting. This is a recent mouse model study that basically is a mouse model of EOE. What they did is challenge these mice with enteric-coated beads that resulted in allergen-specific IgE, specific IgG1, and this induced a Th2 type phenotype in these mice. So they also have an eotaxin knockout mice, and what's fascinating is in the placebo group, the eotaxin knockout mice were still able to form a response to this allergen-induced model. But in the eotaxin knockout mice, they did not have a great response, meaning eotaxin, and this is eosinophils in the GI tract, and from what I understand from mice, it's not just the esophagus, it's all the GI tract. But these eotaxin knockout mice were much less likely to form this eosinophilic esophagitis type model. So knocking them out was effective. Now they also, interestingly, have another model of an IL-5 knockout mouse. And down here we have the number of eosinophils in the jejunum in the placebo group. In the IL-5 knockout mice. What's interesting is you could actually still induce eosinophils into the jejunum after challenge, meaning even if you knock out IL-5, that these mice can still generate. And that makes sense from one of the recent clinical studies that I will address later. We looked at anti-IL-5 in these patients, and they weren't able to show that there's a significant clinical benefit. Now, what's interesting is these same mice still have a decline in their circulating eosinophils. So it works well in the blood, but in the tissue specifically, the main mediator here seems to be eotaxin, and that would make sense from our clinical studies, especially those involving IL-5. So from this model, they were able to show that what we know basically is that the accumulation of gastrointestinal eosinophils is an antigen-induced process, and we've known that for a while, even in humans. This can occur independently of IL-5. So this IL-5 mediator, and again, this is a mouse model, but our small clinical trials have shown that it's not a great treatment at this point. And eotaxin was identified as the critical regulator of antigen-induced eosinophilic inflammation in the GI tract. Another study in humans looking at eotaxin 3 was a retrospective review that included esophageal biopsies from consecutive patients from 2001 to 2007. These are in paraffin, the biopsy specimens from the esophagus, and RNA was extracted from them. And there was a significant increase in eotaxin 2 in the normals versus the EOE group, and that's not surprising, but what was a little surprising and may have some diagnostic utility moving forward, even the patients with GERD or reflux did have a difference in the amount of eotaxin they expressed. So this may be a way moving forward to kind of distinguish who is more likely to respond to PPI, because we kind of group these patients into PPI responsive, which you could argue is not true eosinophilic esophagitis, versus non-PPI responsive. So that's why most of these patients now are at least getting a trial proton pump inhibitor therapy. This is another interesting study that recently came out. It's a genome-wide association study of EOE patients and genotyped approximately 550,000 SNPs. When I was a resident back in 2007 doing this, 2 SNPs took me about a full day in the lab. So it's amazing the amount that they're able to process at this point. They looked at 351 EOE samples and 3,100 printer rolls, and found some variability, mainly in the area of chromosome 5 to Q22, which is the area that encodes for TSLP. And Dr. Spergel at our Northwest Allergy Forum was talking about this a lot when he came out to see us, and thinking TSLP may be a major mediator in a lot of these patients. Once they did this, they actually looked at microRNA or messenger RNA, in normal patients and EOE patients, and found that there was a significant difference between the two. And they say, we have identified the first genetic association with EOE predisposition at 5q22 implicating TSLP, and there was another mediator there called WDR36, maybe genes potentially involved in the pathogenesis of EOE. TSLP, as many of you know, encodes an IL-7-like cytokine that is expressed in the thymus and peripheral tissues and regulates dendritic cell and Th2 inflammatory process. And WDR36 encodes a T cell activation protein. Not exactly sure if that's going to be involved or whether it's just TSLP, but these are things to look forward to. And eotaxin plus the TSLP are the two main mediators, at least in my review, that are receiving the most attention at this point. Now, there are no studies in humans, as far as I'm concerned, in TSLP specifically with eosinophilic esophagitis, but I think this is where that's headed. So, the consensus statement, which is what was put out in 2011, so this is several years ago. These are the bottom lines they come out from all of this. The clinical utility of specific genotypes to predict EOE prognosis or diagnosis is not yet ready for clinical application, but it may have a role in the future. Also, esophageal gene expression is likely to emerge as a key molecular analysis, and eotaxin, I think, will be the next thing people start looking for once they get these biopsies. Look at eotaxin concentration, and the ones with higher eotaxin concentration, I think, will be more likely to respond to those PPI therapies. And clearly, genetic factors contribute to EOE. Obviously, that's not a major role yet, but this TSLP, I think we may see things in the coming years regarding anti-TSLP studies involving EOE patients. So epidemiology, and I found this very interesting. So, I'm seeing more and more of EOE in our clinics, and I'm sure a lot of you are as well. So this is a cohort out of Olmsted County in Minnesota, and they looked at what the incidence of EOE per 100,000 person years was at different time frames. From 1991 to 1995, it was 0.35 per 100,000 patient years, whereas in 2001 to 2005, 9.45. So it's increased exponentially, but it's much more common as far as diagnosing this disease. So the prevalence and incidence is much higher than previously reported. And they also looked at this. I thought this was an interesting study. They looked at the amount of EOE that was diagnosed, and there was a seasonal variability with this. But they also looked at the number of endoscopies that was performed. So, are we just performing more biopsies that are diagnosing this, or is EOE indeed on the rise? And again, I think it's a combination of both. Another study, this is by Jonathan Spergel, where he surveyed physicians, and a total of about 1,800 responded out of 10,000 requests. And that estimated the overall prevalence of 52 out of 100,000, which is a fairly good number. And he also looked at where these diagnoses were taking place. And interestingly, the most common area is in the Northeast. Again, whether they're performing more endoscopies there, it's hard to say. The South was the second highest, the West followed by the Midwest. So it'd be interesting to see what proportion of these people are actually getting endoscopies, see if there's a bias there. But another study I'm going to go over does also show that it seems to be higher in more cold environments or north environments. Another cross-sectional study from esophageal biopsies from 2008 to 2010 in a large database. So they looked at 9,995, or 4.3% of these biopsies with esophageal eosinophilia. And they found somewhat similar patterns. These what's defined as cold areas seem to have a higher incidence down here, as you can see. The next highest was the arid, and the temperate, which actually we fall under, and the cold, and the tropical. the two lowest. So it's interesting. We're not the highest area, but the cold and arid zone seem to be places where this is diagnosed more. So they postulate that geographical and climate patterns may help identify candidate antigens that may help. And is I think another reason, if someone has a clinical history of allergic rhinitis, what we think is allergic asthma, certainly skin prick test and aeroallergens. And this is another study. This is a study out of Florida where they looked at 41 adult patients at one center. And they looked at the seasonality component, and as you can see, from April to May, there was a significant increase in the number of cases diagnosed over that time period. And they do comment in the discussion that their pollen seasons are somewhat similar to us, meaning that the trees really kick up around February to March, and then the grasses are usually at their peak in June and July. So there may be some role to aeroallergens in this disease as well. When patients were grouped seasonally, there was a significant increase in the spring and summer months compared to the fall and winter. So these patients also had a fairly high incidence of rhinoconjunctivitis, asthma, and they looked at two different cohorts from different time periods, and both of them showed similar results in higher rates of asthma. They admitted that they didn't skin test a lot of these patients, which may be the incidence of low aeroallergen sensitization, but asthma, rhinoconjunctivitis, food allergies are relatively high in this patient population. So from these consensus study, they say the complete evaluation of patients with EOE for aeroallergen, and I did not know they were recommending this, is frequently warranted in both adult and pediatric patients because it might change management. And also they say when you're looking at a biopsy or when someone was diagnosed, you should look at the pollen count in those areas to see if they correlate. We talked about that. So again, not only testing for foods depending on what your process is, but also testing for aeroallergens is something I think after preparing for this talk is something I may consider doing more, especially if there's a clinical history of allergic rhinitis in a lot of these patients. So the more tricky area here is what is the role of foods? And we all know that there are a role of foods in both kids and adults with these conditions. So this is a study that, from what we know, kids seem to do well on an elemental formula. But this is the one study that I was able to find that looked at the efficacy of elemental diets in adults. It should be very tough talking with my patients that come in with this. So they used 18 adults and performed elemental diet for 4 weeks and looked at symptoms and histologic findings based on every 2-week biopsies. 6 subjects were actually rebiopsied 2 to 7 days after resuming a normal diet. And they found the following. So, as far as a histologic response, there was a nice response here. So, where therapy was introduced, and 2 weeks after therapy was introduced, they did have a sharp drop in the eosinophil count that was consistent through 4 weeks. Interestingly, mast cells also declined on this elemental formula diet. There was complete or nearly complete resolution. Nearly complete was defined at less than 10 eosinophils per high-powered field and 72%. So a good proportion of these patients, at least histologically, do well on this diet. Now, of those 29 subjects, 11 or 38%, a very high percentage, failed to adhere to this diet, even in the study. So you can imagine if you're sending these patients out and you're adults in clinic on an elemental diet, they're not going to be thrilled, and I don't think adherence should be that high. Several patients had significant weight loss, presumably these are the ones that had actually adhered to the diet. Symptoms and endoscopic fixed structures did not improve. And they used the Mayo Dysphagia questionnaire 30 to quantify that. And this I thought was fairly amazing too. The people that responded, they actually reintroduced those foods and performed biopsies at 2 days, 3 days, 4 days, 7 days. And those eosinophils are fairly rapid as far as their reintroduction into the esophagus in these patients. So, while the elemental diet works from a molecular level, it looks like the symptoms did not improve and the adherence was very low. So I would be very hesitant to put at least any of my adult patients on elemental formula diet. Now, this is another major study, at least in the adults, which is mainly...
Why didn't they think they improved? Here you got histological evidence. What was their hypothesis? They were cheating on the diets, or?
Well, they improved histologically, but their symptoms...
That's right, but why not?
No, whether they were just unhappy, there was no control group in this, whether they were just unhappy with the diet. It really is hard to say. So I don't have an answer for that, neither did they going through. But certainly histologic, there was a response, but symptoms were unchanged. Now this is a landmark study, especially in our patient population, seeing mainly adults, where they assessed the 6 food elimination diet: wheat, egg, milk, peanut, soy, tree nuts, and seafoods, depending on which you use. So they looked at histologic response, symptoms, and quality of life in patients with these. After 6 weeks of the SFED, they had repeat EGDs, biopsies, and histologic responders were defined by 5 eosinophils for high power field. So again, 50 patients with EOE, they were started on the SFED for 6 weeks. They rebiopsied them. Histologic responders were less than 5 eosinophils. And then they had systematic reintroduction, followed by EGD and biopsy in a lot of these patients. Symptoms and quality of life, again, were 2 other measures they used in this diet. They also performed skin prick testing, although they don't go a lot into the study when reading through it on actually what they tested. And they have basically a small paragraph in the results saying they didn't have a high positive or negative predictive value. So, after 6 weeks of treatment, similar to the other study, this seemed to work very well. The mean eosinophil count in these patients in the proximal esophagus went from 34 to 8 eosinophils. Same with the distal esophagus, 44 to 13 eosinophils. And symptoms actually decreased significantly. When they did reintroduce these foods, the 2 most common in this group were wheat and milk, which I think a lot of us know and often will discuss with the patient if they're interested in elimination. Again, they didn't go into this a lot, but they said that skin prick testing predicted only 13% of the foods that were thought to be the cause of eosinophilia on reintroduction of those foods. And their conclusion was that an elimination diet significantly improves symptoms and reduces endoscopic, basically histologic features, and food reintroduction reinitiate features of EOE. So, I think these are fairly decent results to say that histologically, as well as from a symptom standpoint, patients do get better on this diet. It's hard to say why this versus the elemental diet it showed that symptoms did improve. I mean, it's possibly because the patients had more control over their diet, what they're eating, and probably were more adherent as well. So at least in my adults, I've never discussed even an elemental formula diet, and this data I think would back that up, whereas the 6 food elimination diet does improve symptoms as well. So I think from an adult standpoint, this would be where I would go.
So Drew, did they add the foods back 1 by 1 then? I mean, I guess, okay, yes. Trying to figure out how they implicated.
At least that's what I got out of it. Now, Jonathan Spurg will talk with us in the beginning of the year, give a few fabulous lectures, and as far as food testing, again, I admit I'll often do it in my adults, mainly because it gives me some control over the visit, and while the skin testing's cooking, I'll talk about positive, negative predictive value, whether these are actually going to be helpful, and it also gives me time to talk about elimination diets, and or medications, because I think adults, in my experience, either want one or the other. Often don't want to do both, and are very opinionated on which they would want. This is a huge study. Dave, I was hoping to be here. He probably contributed to this study, but it was a retrospective analysis, and this is in children with EOE seen at CHOP, and they have a huge cohort there, obviously. And they had a total of 941 patients with EOE. Here is their standard panel. So they do meats, so beef, chicken, turkey, pork, grains, rice, wheat, barley, corn, oats, vegetables, string beans, which I've never tested, peas, carrots, potatoes, fruits, apples and peaches, milk, soy, peanut, and egg. And they also have a discussion with the patients or the patient's family. What foods do you eat a lot of? And if there were those foods, they would also test them as well. Their definition of food causing EOE was determined based on the addition of one food after they've driven down their eosinophils on esophageal biopsy that will change from normal to greater than 15 per high-powered field. And excluded patients who were on swallowed corticosteroids, or they must have had an anti-L5 study going there. So they excluded those, but in total, they identified 319 patients where the cause of the food had been identified and then analyzed, whether skin prick testing is helpful in these patients. And they also did patch testing. So again, what it sounds like is they do the skin testing first. If they have a positive result, they won't do the patch testing, especially if it's a significant positive result. But the patch testing is guided by the negative skin testing. So, as far as the definitive foods causing EOE, milk, egg, wheat, and soy were the most common, and that's not surprising, I think, to any of us in the room. About 15% of these patients had urticaria anaphylaxis, so more of an IgE-mediated response, which is certainly higher than the adult patients I see. So what they look for is a negative predictive value, and if you think about it, that's the most important with these patients. If both tests are negative, what is the likelihood of reintroducing this into the diet is going to be helpful? Because you want to always reintroduce as many foods as possible. So, for just skin prick testing, the negative predictive value is reasonably high, actually. I was surprised in egg, wheat, soy, peanut, beef, corn, chicken, potato, and pork. But if you look at here, the milk is relatively low, 29.3. When you combine these data, I'm sorry this is very small, but you get an increase in most of these numbers. But interestingly, milk, even with both of these test modalities, goes from 29 to 44%. So milk is not a great testing modality in these patients. So they analyzed where did they have the most success in finding a diet for these patients. And if you can see down here, the highest success rate was in allergy testing, which they do, again, a skin prick test and patch test, and they empirically eliminate milk. And they said 70% of these patients actually had a clinical response or had a sustained clinical response being on that diet. The next highest was milk, egg, wheat, soy, and all meats. Interesting, the 6-food elimination diet was lower in their experience in the pediatric population. Again, this is not looking at adults. And their conclusion was that an elimination diet based on skin prick and patch testing leads to a resolution of the esophageal eosinophilia in a similar proportion to empiric elimination of foods, but required that fewer foods were removed. And I know when he had talked at the Northwest Allergy Forum, he was an advocate for this just because, especially in their pediatric population where weight is always an issue, they want to reintroduce the most amount of foods possible. So, if you have the resources to be able to do these in these patients from this study, it looks like it's a reasonable option. I don't know if any of you around here have been patch testing. Frank, do you do it?
No.
Yeah, I know Dave was doing it, but I'm not sure if he's doing it anymore. Because it is a lot of legwork to get this done. But, at least at this center, and again, this is one center, that's their success rate with each of these individual treatments. So from the clinical committee recommendations, they say dietary therapy should be considered in all children, and I certainly agree with that. also would like to limit the amount of meds they're on. Adults, they were a little more soft on it. Should also be considered for motivated adult patients, and that's another thing when I'm placing those skin testing. I come and I talk with them, what would you rather do, be on a medication, or would you rather try and eliminate this with diet? And people are always usually one way or the other. Most people want medication because they want to eat as many different things as they can, at least in my adult patients. They recommend getting these patients established with a dietitian, and most of the patients I see are. And I would say that's certainly true in the pediatric population. And the adult patients, even patients that are on the food elimination diet, usually can keep their weight up. And this is another issue. Restriction of foods that prove to trigger EOE might need to be continued indefinitely, and that's interesting, and I think that's something else that we'll find out more in the coming years. Because of the high rates of food allergies and anaphylaxis and EOE, serum and skin prick testing for immediate type hypersensitivity is warranted in a lot of these patients, and that's another way I can justify skin prick testing, although again, in the adult population, that seems to be less as far as the IgE-mediated anaphylaxis playing a role. But certainly in kids, I think it's worthwhile to some extent. So this is how they phrase the data on food and food patch testing and serum IgE. They said although skin prick testing, serum IgE, and food patch tests can be used to help identify foods that are associated with EOE, these tests alone are not sufficient to make the diagnosis of food allergy-driven EOE. So kind of hedge their bets on that. So next, as you know, the two main treatments for this are proton pump inhibitors and the swallowed or inhaled and swallowed corticosteroids. So, I usually do recommend PPIs in these patients if the GI doc hasn't already put them on it. But I didn't really know why, as far as other reasons up to date, and I'm recommending it. So there's a few studies that have been cited in regards to this. So one study involved 36 children who were initially treated with 3 months of high-dose PPI therapy and had a subsequent follow-up EGD. And they classify these into two groups: the patients with a histologic response and patients with no histologic response just after PPI therapy. So, what's interesting about this study, and it was not a blinded study, is that 28 of the 36 patients actually had an improvement in their dysphagia scores after 3 months of the high-dose PPI therapy. And that was regardless of whether they had a histologic response, which was much less. 14 of the patients that were placed on the high-dose PPI therapy did note a histologic response. But no histologic response was noted in 22% of these patients, which seems to be, from reading some of these other studies, about the average. About 30 to 40% of these people seem to respond to the trial of high-dose PPI therapy. So again, I think it's warranted, and after reading through all this literature, if they haven't tried that, that's certainly one of my first-line agents that I'm going to be putting them on. Another study looked at high-dose PPI therapy in children and looked to see whether the responders were different than the non-responders. So they looked at things like sex, reflux symptoms, abdominal pain, dysphagia, nausea, failure to thrive, and see if they could find any difference between the patients that responded to the high-dose PPI and the patients that didn't. And as you can see here, the results were not great. There's really no way, from a clinical standpoint, when they're coming in, to be able to distinguish these two groups. He said a step-up clinical management guided by EGD with biopsies best distinguishes the patients with EE from non-eosinophilic esophagitis. And, in my experience, at least in the adult setting, a lot of these patients are not getting a follow-up EGD after they're placed on proton pump inhibitor. In my experience, a lot of people do get better, but whether they're this non-eosinophilic esophagitis or eosinophilic esophagitis, it's tough to tell unless you do a repeat biopsy at this point. Hopefully that will change in the future. again, this is a retrospective study. This isn't a perfect study. And then a lot of these patients did not complete allergy testing, even though it was always requested by this group. In a similar study, 43 children were involved, and they started PPI therapy. 17 of those patients were considered responders. And again, they looked to see if between the responders and the non-responders, is there any way to distinguish them to see who's going to likely respond to PPI therapy? And they looked at things like asthma, positive skin prick testing, presenting symptoms, endoscopic findings they looked at, although they did not look for eotaxin in this study, which I think may be the one marker that will be validated in the future. Season of presentation, there's really no way to distinguish. All of these NSs are somewhat discouraging. Similar to histologic findings. Again, they didn't look for eotaxin, but the histologic findings on the responders versus the non-responders were not significantly different. What was a little bit interesting is they found that those that presented with more mild eosinophil in the beginning, with 15 to 20 EOs per high-powered field, 50% were responders. When they got up and their eosinophil level increased, as you can see, a lower level seemed to respond. So that may be one marker. If someone comes in with 17 EOs per high-powered field, you may see that they're more likely to respond to the high-dose PPI therapy. And they also looked in this study, although I have another study saying having different results, as to whether an abnormal pH study helps. And really, there was no difference between the abnormal pH and the normal studies. So in this study, they concluded that it did not. So again, we run into the same clinical range of about 30 to 40% that seem to respond to high-dose PPI therapy. And again, none of the clinical characteristics seem to be predictors to see who's a responder and who isn't. Finally, this is another review that looked at a lot of different studies, and they classified people as complete histologic response, meaning they had less than 5 EOs per high-powered field, partial histologic response, 5 to 15, and they looked at symptoms as well. So they included 10 articles with 258 patients with EOE, 152 children, and I haven't reviewed any of the adult data, but this did include adult data as well. As far as a clinical response, in children, a fair amount of them seem to have a clinical improvement. Again, most of these weren't blinded studies, so it's hard to tell whether that's a placebo effect, but their rate of histologic remission was from 23 to 40%. Again, that same range we keep seeing over and over. In adults, the symptoms, there's a wide range here, but again, most adults seem to see a clinical improvement on PPI therapy. Histologic, again, was much lower, so it's hard to tell what's going on there. Among the PPI responsive patients, PPI was more common with documented GERD. So as opposed to the previous study, which did not show a benefit, this group actually recommended trying to get a pH study to see whether they're more likely to respond versus not. And they say symptom improvement is common with PPI therapy despite persistent eosinophilic infiltration. So, and we were just talking about this. All these patients, I think, in my opinion, need at least a 2 to 3 month trial about PPI therapy. So, and again, the clinical committee agreed with this, saying PPIs are useful to help eliminate GERD as a cause of esophageal eosinophilia. PPIs are useful treating patients with EOE, in whom GERD is a comorbid disease. And then finally, although the mechanism of PPI is thought to primarily involve acid blockade, PPIs may also affect esophageal eosinophilia by other means. There may be another way this is benefiting those patients. So, PPI therapy, and I also start a lot of people on topical steroids, so I reviewed a lot of the data there. So, this is an adult study of 19 patients that received 4 weeks of swallowed fluticasone, 250 micrograms, 2 puffs twice a day. And they looked at, again, symptoms, assessment, and endoscopic biopsy. In regards, most of these patients, or all of them, had been treated with PPI therapy. And most of them still were on PPI therapy in addition to the inhaled corticosteroids, which is the case in most of these patients. And in patients that still had persistent eosinophilia despite proton pump inhibitor, adding this therapy did significantly decrease eosinophil count. So from 24 to 4.6 in the proximal esophagus. In the distal esophagus, they also saw a significant decline. So histologically, it does seem to improve symptoms. And they say that all 19 patients had a dramatic improvement. And again, this is dysphagia symptom scores, pre-treatment versus post-treatment. So, and 11 of these patients they know became totally asymptomatic, which is great. Again, after you start a PPI therapy, I think in adults this would warrant at least a trial of fluticasone. Now, this is a different study involving budesonide, and I know Dr. Spergel had recommended budesonide in kids just basically because it's easier to give. Although most of my patients, when I discuss the two therapies, most of them prefer the inhalers actually. So I think that's interesting. So this was a placebo-controlled study. So they had budesonide in 15 and placebo in 9, and all of these patients had been on lansoprazole. And they treated them for 3 months. So responders were less than 6 EOs per high-powered field. They had partial responders and non-responders, as you can see here. And from a histologic standpoint, again, most of these patients improved in the budesonide group. Now, in the placebo group, they did not see any improvement. So that is a strong evidence that adding budesonide or adding a swallowed corticosteroid in addition to proton pump inhibitor therapy is a reasonable course of action in these patients. Again, the symptoms decrease significantly in month 1, month 2, month 3, as compared with the placebo. So there certainly is something to this from both a histologic standpoint and from a symptom standpoint. So adding these steroids is very reasonable, I think, as a next step there. Budesonide is an effective treatment of panesophageal disease. Patients with EOE, budesonide improves symptoms and endoscopic histologic features. So again, this backs up this notion that for patients that don't respond to the PPIs, that adding them to PPIs with inhaled corticosteroids, or swallowed corticosteroids, is a very reasonable option. So the clinical committee made these recommendations. So topical corticosteroid should be considered in all patients and adults with EOE for both initial and maintenance. The type and duration of steroid therapy depends on disease severity, patient lifestyle. Again, I always have the discussion, would you rather avoid foods or would you rather start these different medications? And again, the natural history of this disease is poorly understood, but they recommend the corticosteroid if they need it initially. It might need to be maintained long term, but that's individualized for each patient. So I think, the PPI therapy, obviously, and the swallowed corticosteroids, there's some good evidence backing that up. Now, people were really excited about the anti-IL-5 study. Now, this is a relatively small study. 11 adults with EOE, and they're randomized to receive either 750 milligrams of pembrolizumab, and that's the dose that we give monthly, actually, for our hyper-eosinophilic protocol at UW. And again, only 5 received pembrolizumab and only 6 received placebo. So you may argue that this needs a larger group to completely rule this out as an effective therapy. So if they didn't get remission after the first biopsy, then they gave them even higher doses, and this is a pretty whopping dose of pembrolizumab, 1,500 milligrams. So here's the placebo group, here's the mepolizumab group. As we know, and as we've seen in our patients, Anti-IL-5 is an incredible drug as far as dropping serum eosinophil counts, as you can see here. Even after the first dose, it drops it precipitously. So as far as peak esophageal eosinophils, that dropped too in the mepolizumab compared to the placebo. Same with mean esophageal eos compared to the placebo. Now, in the patients that didn't respond initially, the 2 extra dose of more high dose mepolizumab did not offer any more benefit. So higher therapy did not seem to improve this condition. Now, the problem with this study and why it hasn't gained a lot of traction is that the symptoms did not really improve after this study. So this is days with dysphagia, or days until you develop dysphagia. So they thought that there's a mild difference here initially, but after all the doses of mepolizumab, there really was no difference in the amount of dysphagia that these patients were experiencing. So unfortunately, although mepolizumab significantly reduced the eosinophil counts, there was minimal clinical improvement that was seen in this group. So,
Drew,
yeah.
you mentioned that CHOP was doing in kids with IL-5. Did you find that data? Has that been published yet?
No, I haven't seen that. But this was the study that's most often quoted, and they may be coming out with that data later, but I haven't seen it. And as far as I know, anti-IL-5 unfortunately is not something that a lot of people are looking into given this preliminary data. But as you can see, it's a very small study, so further study may be warranted. But going back to that mouse model, it makes sense why that didn't work, and I think attacking eotaxin would be the logical next step in this. So Xolair, does this work? So this is a group out of Utah that studied this, designed to test the hypothesis that EOE is IgE. Bottom line, to cut to the chase, again, Dan reviewed this study earlier. It was a flop. So in some, they were looking at immunoglobulin classes in esophageal mucosal biopsy specimen, and then further studied things like IgM, IgA, and actually looked at IgG4 in these patients. So what it was is a prospective, double-blind, randomized, placebo-controlled study with 30 EOE patients randomized to mepolizumab or placebo every 2 to 4 weeks, and this was weight and serum IgE based, similar to asthma. And then they performed endoscopy and biopsy with symptom assessments at baseline and at 16 weeks. And bottom line is, eosinophils were not significantly affected, neither were symptoms. So this was thought to be, a failure as far as the treatment. But I think they said, geez, we have no data here, so let's look into some other things. And what they did is look at esophageal biopsy specimens. And stains for, I think the original idea was look to see if IgE is decreased. But they also looked at these other subtypes. They looked at IgM, IgA, IgG1, 2, 3, 4, and noticed a trend. So it's an interesting study because then they frantically try to get specimens from outside studies. So they brought in a lot of different biopsy specimens and analyzed them. And they also got serum from a lot of these patients as well. Using ELISA, they looked at IgG4 as well as specific IgG4 in a lot of these patients. So they found that the mean mucosal IgG4 content is 45-fold increased in patients with EOE as compared to controls. When they looked at the other subclasses, IgA, IgM, IgG, the other subclasses 1, 2, 3, there was no significant difference, but there was a striking increase in IgG4 in these biopsy specimens. They went into the specimen and looked for immunofluorescence for IgG4 and showed that granular intracellular IgG4 immunostaining in 21 of the 24 subjects looked like this. So as you can see, this is the EOE patients as opposed to the control, and there's striking differences in between the two. And these are other ways to look at it. They found in the EOE patient population clusters of inflammatory cells on the lamina propria, found plasma cell infiltrates, and most interesting, they found abundant IgG4 plasma cells in the deep lamina propria in these patients. So high that it was 300 IgG4 plasma cells per high-powered field, which was striking, and this was seen in a lot of different numbers of these patients. Now, they looked at serum IgG4 as well, and the total was increased, but it wasn't striking. But when they looked at specific IgG4 to things like wheat, things like eggs, nuts, milk, they found a significant difference between the placebo or the controls versus the EOE patients. And they did note that while there was a trend this way, a lot of the control patients actually still had high IgG4, so it's certainly not pathognomonic, but they did find this trend, which I found interesting. So the conclusions of this study was omalizumab did not help at all, but IgG4 kind of was they kind of incidentally found, in my opinion, there's a 45-fold increase in esophageal tissue IgG4, and IgG4 antibodies to common trigger foods were present in most eosinophilic esophagitis patients compared with control. So they kind of say it's not likely an IgE-mediated phenomenon, although that's somewhat simplistic in the way they word that, but evidence that despite the frequent presence of IgG-bearing mast cells, adult eosinophilic esophagitis is not IgE-mediated, possibly because of blocking IgG4. Their postulation was that people initially have an IgE response that's compensated for by IgG4 blocking antibodies, presumably, and that this is kind of revved up to the point where it can become pathologic, especially in certain patients, although that is yet to be proven certainly. They also talked about whether this could be one of these IgG4-related diseases, and the similarities between IgG4-related diseases and this disorder was there are numerous plasma cells, there's granular IgG4 deposits and fibrosis, but it's dissimilar in a lot of different ways, whereas IgG4-related disease usually presents as distinct masses or strictures. They typically have a different pattern of pathology, including storiform fibrosis and obliterative phlebitis. Don't ask me to say that again. The total IgG4 is increased minimally in eosinophilic esophagitis. Although, as we know in IgG4-related disease, the total IgG4 is not always elevated. And they postulated this could be due to the more small tissue compartment that these IgG4 cells reside in. So, although there's in general, and this is stepping back to they're basically saying that, while this is interesting data, we don't recommend or covering their bases. We don't want all these patients stepping out and getting IgG4 testing, and that the prospective trial is certainly necessary to determine whether this has any legs whatsoever. Also, this was mainly in one center, and it needs to be identified in other centers as well, in my opinion. Running short on time, we want to get to questions. We already covered a lot of that. So, to kind of wrap things up, the disease is an isolated eosinophilic disease in the esophagus. Other causes, and mainly GERD, should be excluded. So again, they recommend checking. They recommend at least giving them a trial of PPI therapy, plus or minus being followed by endoscopy. This disease should be remit with dietary exclusion, and again, especially in adults, I think that's something you can talk about, but it ultimately comes down to patient preference. Again, hopefully we'll have a better biomarkers in the future, and hopefully treatments may be coming down the line, the anti-TSLP, the biomarker of eotaxin in the biopsy specimens to help identify GERD versus non-GERD associated. So we've covered on a lot of this. The GI literature has also kind of had their practice parameters. And this is what I found interesting. gastroenterologists should consider consultation with an allergist to identify and treat extraesophageal atopic conditions and assist with the management of EOE, and to help guide elemental and elimination diets. And recommendation was conditional and evidence was low, so you can see what they think about that. That being said, I think most of the EOE patients in our institution are sent to us initially. So after reading all of this, and again, this is mainly in adults, this is my algorithm. So again, I think it's warranted everyone at least get a trial of high-dose PPI therapy for 1 to 2 months. Evaluate the clinical response, because again, in adults and children, people seem to feel better after getting these treatments, and then consider repeat biopsy. We may have biomarkers soon, again, that's eotaxin, to see whether there's more GERD association versus non-GERD associated. If there's no response to the PPI therapy, certainly skin testing, foods a plus or minus. In kids, you can certainly make the argument. In adults, again, I will do it oftentimes, but I have the discussion that may or may not be helpful, and that gives me time to kind of discuss treatment options, try and educate them more about the disease. Certainly, after reading this, I am going to start checking more aeroallergens, certainly if the history is there, given, and it's been shown that this can have a seasonal component to it. So after discussing patient preference, a lot of people just want to be on meds because they want to eat everything they can. I usually use the swallow fluticasone, but in children, I know budesonide, and a lot of people, it's a preferred way to go. And then if dietary management is preferred, elemental diet in children, again, that study in adults, as far as the symptoms control, and as far as compliance, I certainly wouldn't recommend that in a lot of my adults unless they're extremely motivated and want to try that therapy. 6 food elimination diet, especially in adults. And in children, certainly testing for food, skin pre-testing is it's quick, it's easy, it's cheap, so oftentimes avoiding milk, certainly in adults, I often recommend that as well. And if you have the resources in children's, I think you can make a reasonable argument to skin prick and patch test, given the spermal data. But, I find one of my major roles when seeing these patients is patient education, because they come in, they get this biopsy about something regarding eosinophils, they don't know what they are, is it allergic, is it not? So I'll sit down in the time that skin testing is usually going on and just discuss this disease. And I think the more they're aware of the different treatment options and the fact that we often do tailor the treatment to their preferences, I do think that they really do appreciate that. What time is it? 8:01, perfect. All right. Don't have a lot of time for questions, but anyone have questions, certainly comments?
Here is an outside question from, let's see, it was on adult elemental diet. What was the average length of time the diet was performed before symptoms were assessed?
Let me go back to that. It's in there. I think it was 3 weeks, 6 weeks.
The implication of the question was the lack of symptom relief due to a delay in improvement of symptoms compared to improvement of the histology?
I also think, and I mentioned that briefly in there, but there was a high rate of non-compliance in that study. I think that would probably contribute at least some to that. But let me find that with the treatment was. But yeah, this was really hard for adult patients, and I've yet to meet someone in my clinic that would say that they would be willing to try this treatment.
Powder, powders, and a slurry, shape.
4 weeks. So, yeah, you could reasonably make that argument, but again, I think in our adult patients, going to an elemental diet, short term may be an option, but long term, at least in my experience in talking with these people, is not something I typically recommend. I bring it up and say it's an option, but yeah, the histologic response was reasonable. I agree, but maybe they were grouchy when filling out their questionnaires because they were on this diet. It's hard to say.
Amgen's got that anti-TSLP molecule.
I know for the asthma, I'm sure studies are going on. I looked up last night to see whether they're enrolling anywhere. I didn't see anything, but I'm sure someone's got something.
It'd be good for independent investigator trial.
I agree. I think that, and Spergo mentioned that when he came out for the Northwest Allergy Forum. He said that TSLP, I think, is going to have a major role in this disease moving forward.
Did you come across any animal models where they tried to, I don't know, torture animals with bad reflux and so forth to induce this? I mean, it makes you wonder, almost every one of these studies, there's a big chunk of patients where foods make no difference. That it almost feels like, you know, rhinosinusitis, where like ENR patients might be atopic, and that makes it worse.
No, I didn't run into any.
You know, and obviously if you're atopic, then you have foods going into an abnormal esophagus, so it makes sense that, you know.
Actually, one of the discussions that it brought up that possibility as well. It's more than just acid production. And so no, it's interesting. I did not run into any mouse models, but it would make sense from a pathophysiology standpoint.
Drew, so the protein hydrolysates are okay. I mean, they're a good substitute for cow's milk. What protein in the cow's milk is the bad one? Do you know which?
I don't think we know. I'm not sure, and I'm trying to remember what the exact formula they used, and I can't remember off the top of my head. But I don't think we know exactly which is the protein specifically that drives that. If it is known, it's not known by me.
Whether, camel milk is good or
Camel
Start new business.
Mare's milk.
All right, well, you sleep in next Tuesday.
I know. What is cow's milk? Camel milk or goat milk?
What's that?
Cow's milk? What are they close? What are they called?
Goat's milk.
Goat's milk?
85%
Yeah,
the same. But mare's milk is quite a bit different.
Can they drink camel milk?
I don't know. That's what I put in.